Good morning. My name is Jakub Frączek. This is my colleague Magda Duchińska. We're going to coordinate today's session. We'd like to welcome all participants, all of you, and members of our scientific committee. Today we are honored to guest Professor Rafał Jankowski, Head of Angiology Ward at Second Department of Internal Medicine of the Jagiellonian University, and President of Polish Society of Interdisciplinary Intensive Therapy. We have Dr. Serediński today with us, Provincial Advisor on Anesthesiology and Intensive Care from the First Department of Anesthesiology and Intensive Care, and PhD student Anna Włodarczyk from the Second Department of Internal Medicine. Thank you all for coming. Of course, welcome all who have come to see our session today. We hope you will enjoy it. I would like to sincerely thank the Polish Society of Interdisciplinary Intensive Therapy and Polish Society of Anesthesiology and Intensive Care for patronage and for funding prizes for our session. And special thanks go to ultrasonography section of Polish Society of Anesthesiology and Intensive Therapy. Our workshops will take place tomorrow, and we've been able to organize them thanks to the society. Before we begin, we would like to remind you a couple of regulations for today. You have 7 minutes for your presentation, and then we'll proceed to a 2-minute discussion. Of course, the official language is English, and you'll have awards for first, second, and third place. The results will be announced at the end of our session when the jury debates. And the best participant will be awarded tomorrow at the closure ceremony. Now I would like to pass the microphone to Magda. Thank you.
Thank you. And now I would like to call on Sylwia Bartyzel to make her presentation, The Impact of Procedural Sedation and Analgesia on Memory Loss in Patients Undergoing Fiber Optic Bronchoscopy.
Good morning, ladies and gentlemen, dear colleagues. My name is Sylwia Bartyzel, and I represent the student scientific group at the Second Department of Internal Medicine of the Jagiellonian University Medical College in Krakow. I would like to present to you a paper titled The Impact of Procedural Sedation and Analgesia on Memory Loss in Patients Undergoing Fiber Optic Bronchoscopy. Fiber optic bronchoscopy is a common diagnostic tool used to evaluate patients with various respiratory diseases. As an unpleasant and invasive procedure causing anxiety in patients, is usually performed under analgesic sedation. However, the use of procedural sedation and analgesia, PSA, during fiber optic bronchoscopy and its impact on patients' comfort, patients' memory loss is still a matter of debate. This study evaluated impact of procedural sedation and analgesia on memory loss in patients after bronchofibroscopy. Patients who gave us written consent to participate in the study were administered solution of lidocaine, fentanyl, and midazolam. Additional doses of those drugs were given if needed. To gain a complete understanding of their satisfaction, patients were asked to complete questionnaires detailing their experience. Usually it was how about memory loss, time of full consciousness and regaining strength, comfort during and after procedure, and of course side effects of bronchoscopy. 463 patients were divided into 2 groups. Group 1, those were 268 patients who underwent the bronchoscopy for the first time in their life. The other 195 patients were, those were patients who underwent this procedure once again under analgesic sedation. Person chi-square analysis and 2x2 contingency tables were used for statistical analysis. Our questionnaires distinguish 13 details of the procedure which could be easily remembered by the patients during the procedure. They were divided into two main parts, two main sections of the procedure, before and after drug administration. Please notice that over 90% of all patients remember what happened before the drug administration in both groups. Parts of the procedure, like lidocaine administration or lying down on a treatment table, were remembered even by 99% of the patients in both groups. Important thing is also that there were no statistical differences, significant statistical differences between both groups. After drug administration, as we could expect, patients were able to recall less details from the procedure. Individual parts were remembered by 90% of 90% of patients, like sucking out of saliva, to 52%, introducing the mouthpiece of the patients. However, there were some significant differences, as we see here. And the patients who underwent the bronchoscopy for the second time, remember more details from the procedure, like dizziness after drug administration, placing of the mouthpiece, suction of saliva, parts of the conversation by medical staff during the procedure, or additional drug of doses. After the procedure, 54% of patients regain full mental ability right after the procedure. It was a time 5 to 10 minutes before they leave a bronchoscopy room. Another 40% of them needed more time, but it was maybe about 30 minutes where they were entering to the ward right after procedure. There were no significant differences between both groups, no matter how many times patient underwent bronchoscopy. Despite the early regaining of the full mental ability, full mental ability by the patients, only 12.5% of all were able to regain full strength recovery after the procedure. Over 68% combined needed 2 hours or even longer to not feel fatigue after the procedure. Of course, there were no other significant differences between both groups. Well, our study revealed that the patients who underwent the bronchoscopy for another time remember more details from the procedure. However, the using of PSA of course, showed lasting memory and fatigue, but after the procedure. I would rather further point out that against common opinion, PSA does not cause in this study retrograde amnesia and should be a gold standard during fibrotic bronchoscopy. Thank you for your attention, and I'd like to invite the discussion.
Are there any questions? Comments? Yes, Anya?
I would like to ask a question. Were there any complications after the sedation in patients you investigated? Any serious complications?
Serious complications. There were one patient when we got a problem with regaining consciousness after the procedure. This patient needed 5 doses of flumazenil to regain consciousness. This was the only one for those 463 patients, the only patients that we got really serious worry about the patient's life. During the procedure, there were less complications, less severe complications like cough, bradycardia or apnea, but there were in moments of 2 minutes at max, nothing more serious.
Thank you.
I have a second question. Why you use this method for analgesication? Midazolam is old drug to sedation. We use now propofol the most because it's not so long and give less adverse events. Why midazolam with fentanyl? Fentanyl lasts about 40 minutes. This dose is too low to analgesia, you know?
Yes. Why we use midazolam? So our department is not the department where the bronchoscopy was were performed. It's not a typical anesthesiology and intensive care department. And from all I know and the team I worked with, now we cannot use propofol without presence of specialists from anesthesia and intensive care. And that's why the midazolam was used with fentanyl, because it could be induced by the doctors who's not, for example, specialists from internal medicine or...
I know that it was not your choice, but it's standard method for this procedure in this unit, yes?
Yes.
Midazolam with fentanyl.
With fentanyl, yes.
For my commentary is that not good method for this procedure, I think so. Thank you.
Thank you for your comment.
Thank you. Are there any other questions? No, thank you very much, Sylvia, for your presentation. Applause for Sylvia. I'm sure Sylvia did not exceed the 7 minutes we have, but now the timer will be on. So the next participant will be, just a second please. Magdalena disappeared. She knows the right order. Okay. Now I'd like to call on next speaker, Magdalena Sławek, to give her presentation, Epidemiology of Anesthesia for Cesarean Delivery at the Tertiary Care Hospital.
Good morning, honorable committee, ladies and gentlemen. My name is Magdalena Sławek, and I'm from Jagiellonian University Collegium Medicum. I am representing anesthesiology and intensive care student scientific group. Together with my colleagues, Aleksandra Sobocińska, Natalia Stawowska, and Michał Szczepanek, we would like to present results of our research. Nowadays, cesarean sections is getting more and more popular. Only in 2014, there were 1,866 C-sections, which accounted for over 60% of total deliveries. This huge percentage is probably due to specific of our hospital being a tertiary care hospital. We would like to focus on a type of anesthesia used in this procedure, choice of which depends on the medical indications and the state of mother and fetus. A database for all 1,866 C-sections performed in 2014 was reviewed. Criteria are under evaluation included age, gravidity and parity, medical indications for C-section, with reference to the type of anesthesia divided into 3 groups: spinal, epidural, and general anesthesia. In the last group, also ACA, a physical state classification scale, was analyzed. The most common type of anesthesia was spinal anesthesia, performed in 1,543 cases. It was followed by general anesthesia in 232 cases, and the epidural in 61 cases. In 90 cases, it was a conversion from spinal to general anesthesia. In 61 out of 70 procedure under epidural anesthesia, this kind of anesthesia was satisfactory enough for labor, but in 9 cases, a conversion to general anesthesia was needed. As we can see, the most common indication from C-section under spinal anesthesia was past medical history of C-section. Also fetal asphyxia, failure to progress in labor, multiple pregnancy, and some orthopedic indications were very common. As you can see on this chart, over half of C-sections under epidural anesthesia were due to failure to progress in labor. Also, asphyxia was a very significant factor. There were also many others indication that together sum up to almost 24%, but they didn't play a big role. The most common indications for general anesthesia were some emergency cases, for example, acute fetal asphyxia, and also unknown coagulation states. Also, placenta abnormalities, improper presentation of a fetus, and multiple pregnancy and neurological indications were very common. On this chart, we can see cesarean section under general anesthesia divided by the states of the patients in a physical status classification system. In this system, number 1 stands for normal healthy patient, number 2 for mild systemic disease, and 3 for severe systemic disease. As we can see, the majority of our patients were in group 2. Also in group 1E, 2E and 3E, where letter E stands for some emergency cases. We also took into consideration age of a parturient woman, but it do not correlate with the type of chosen anesthesia. But a number of parity and gravidity correlates with it. And it is worth noting that almost over 90% of cesarean section under epidural anesthesia was connected with the women giving birth for the first time, while multiparous women accounted for less than 10%. We can see the same data on this graph, but for the spinal anesthesia, and it is distributed more evenly. To conclude, the vast majority of C-section was performed under spinal anesthesia. It is cheaper and quicker procedure and linked with low risk of complications. General anesthesia was mostly used during some obstetric emergencies and unknown coagulation state. Age do not correlate with the type of chosen anesthesia, but number of parity and gravidity correlates with it. And for further research, not only data from previous years from our hospital should be gathered to observe some trends, but also from hospitals of lower reference degree. And thank you for your attention.
Thank you for your presentation. Let's proceed to the discussion. Are there any comments or questions? Okay, so now I'd like to introduce Anahit Hovhannisyan, who's going to address the topic of oral tissues trauma during endotracheal intubation.
Good morning, ladies and gentlemen. Good morning, members of jury. My name is Anahit Hovhannisyan. I am from prosthetics department in Warsaw Medical University, and I will start my presentation. Endotracheal intubation is a treatment routinely performed during general anesthesia, and it brings a high risk of complication such as hard and soft tissue of oral cavity trauma and prosthetic restoration damages. The main reason of this complication may be difficulties in performing treatment that result from patient disadvantageous anatomical condition. It consists from the upper incisor considerable transverse dimension, limited movability of temporomandibular joint, malocclusion, especially upper teeth protrusion, retrognathis, and many missing teeth. The general dental practitioner, before carrying out the treatment, may recommend using mouth guards that correspond to the mouth guards prepared for a sportsman. They may significantly decrease the intraoral trauma during intubation. There are various types of mouth guards. There is standard type with universal size. There are boil and bite type, plasticide in the warm water, and custom-made mouth guards, individually prepared by dentists and dental technician workplace by the base of patient's impression. Another method to prevent the intraoral injuries is to use the special adhesive tape. This is the 3M microform surgical tape that projected on a laryngoscope spoon may prevent from the damages resulted by a pressure of metal laryngoscope spoon to masticatory tissue. Due to the small thickness of this tape, the visibility of operation field is not affected, and the laryngoscope spoon does not slip over the front teeth. The aim of the study was to assess the damage during the endotracheal intubation and the prophylaxis procedure performed by anesthesiologists during intubation. The questionnaire was conducted among 52 Polish anesthesiologists, and we elected a question about occupational experiences of occurrence of intraoral damages during intubations, and as the range of cooperation with dentists. In the result, most of our questionnaire observed in anesthetized patient in the five year of practice intraoral trauma caused by intubation. Soft tissue trauma and breaking off the piece of enamel was the most frequent of the injuries. Least number of anesthesiologists observed damage or uncementing the prosthetic restoration. According to the reports, the intraoral injury is more frequent by the anesthetized kids than the adults. Injuries in this trauma occurs in 3 out of every 4 doctors who care kids in age less than 6 years, while the anesthesiologist who cares adults in age to 80 to 50 years, not even the half of them occurs this kind of injury. The next part of questions was about anesthesiologist procedure performed during and after the general intubation. The assessment of difficulty of performing the treatment was used in 92% of anesthesiologists. the 60% of the doctors inform patients about the possibility of intraocular injuries. 83% of them notice this kind of injuries in patients' card. The patient's claim was expressed by 6% of the anesthesiologists. The next type of questions was connected with the anesthesiologist's opinion about the cooperating with dentists and using mouth guards. The necessity of consult to a general dental practitioner before carrying out the treatment is rated by 38% of the doctors. Only 10% of them have ever directed patients to a dentist before injury. Only 4% of our responders has ever met a possibility to use mouth guards operating with intubation, but none of them have ever offered patients to do this kind of prophylaxis appliances. What I think is very interesting, more than half of anesthesiologists consider using mouth guards as recommended. The next part of question was about subjective opinion of anesthesiologists about occurring intraocular trauma during intubation. The half of the anesthesiologists assess this kind of injuries on 0.1 to 0.5% of the patients. None of the responders assessed them more than 10%. In conclusion, when it comes to the intraocular trauma during injury, is significantly important to pay more attention about the prophylaxis that can prevent from this kind of injuries. It's necessary to promote between anesthesiologists a knowledge about the possibility and advantages of using mouth guards, and invited them to offer the patients to consult with the dentist and make this kind of appliances. I think that further studies about the using mouth guards and prophylaxis is necessary. Thank you.
Thank you for your presentation. It's time for the discussion. Are there any questions or comments?
You have presented very interesting data upon differences in age of the patients and connected this age with oral tissue trauma. But did you and your team check it with some statistical analysis, or your conclusion is just upon the percentage?
You mean my conclusion about the what? Because I don't understand exactly the question.
You showed, for example, the slide when you showed the differences in age. You said that there were differences in the children.
Okay. You know, we just question our anesthesiologists about this kind of difference. So they assess that in anesthesiological care child, there are more often this kind of injuries. We have to remember that the child is in the kind of mixed dentition. That's why the injuries are more often in these cases.
Okay, thank you.
You base your survey on the responses of the doctors. So did you try to assess uncertainty of their memory and what they already report to you?
We asked about the last 5 years of a course of injury, the anesthesiologist. So it wasn't like in all of their practice in whole life, but only in the last 5 years of their practice if it's occur any damages.
But different human beings differently remember different cases. So did you use the questionnaire or you use deep investigation like
The questionnaire.
not the interview?
What kind of interview?
You have a choice to have a questionnaire, the written form that you offer to the responder, or you perform the interview.
No,
sometimes
it was the questionnaire.
digging in details.
Yes, we have to remember that the anesthesiologist is a specific and specialist group, and it's not so big. So it was difficult to get them and to ask about this kind. So we conducted a questionnaire by internet, and only in our studies in Warsaw University in medicine, we only there ask like interview our anesthesiologist, but other one we just made internet questionnaire.
Okay, and you didn't. I didn't notice the data about the response rate.
Once again.
I didn't notice any data in your presentation about the response rate. If you ask the doctors to fill in the questionnaire, what was how many of them respond on your request?
That we ask the doctors how many of them respond of our.
You ask doctors to fill in the questionnaire in internet, yes?
Yes.
And how many of them reacted positively on your?
Most of them.
But what is 50% or 95%?
I don't know, because we don't met them. It was like when we go directly to the anesthesiologist and when we meet them in our universities, they don't want to talk about them. I don't know why. Maybe they were afraid. You know, it's not the subject that they want to talk because of the claims of the patients, and they say that the injuries doesn't existed. But when we doesn't we doesn't break out and we make this kind of questionnaire by internet, and then we just was very surprised when the anesthesiologist really think that this subject is interesting, and it's like it's problematic one. So they was very exciting about this kind of questions.
Okay, but so if I understand properly, I'm not sure. You didn't describe exactly the population that you ask. So you offer the open questionnaire to everybody, yeah?
To the anesthesiologist, yes.
Yeah. Okay.
Thank you very much.
Thank you for the discussion. Now, Michał Krawczyk is going to present his research, the assessment of the usefulness of the environmental high test as a predictive factor for difficult intubation, preliminary results.
Esteemed Commission, dear colleagues, my name is Michał Krawczyk. I'd like to present a paper, a study, which is entitled The Assessment of the Usefulness of the TMHT of the environmental high test as a Predictive Factor for Difficult Intubation, preliminary results. I am a member of the student scientific group, the Department of, you just press something, all right, don't worry. All right. At the Department of Anesthesiology and Intensive Therapy and Emergency Medicine in Zabrze. Professor Hanna Misiołek is the head of the department as well as the head of our group, and the tutor of the study is Dr. Szymon Białka. Performing direct laryngoscopy and endotracheal intubation are some of the most important procedures in general anesthesia, and difficulties. And in carrying out these procedures, they pose a serious threat to the patient's health. Thus, it is crucial to identify patients with so-called difficult airways. And to identify those patients, various tests are available that measure anthropometric parameters of the patients. However, none of these tests that are in use present satisfying predictive value. Recently, it's been discussed that the thyroid mental height test may be used as a single predictive test to predict the occurrence of difficult intubation. The thyroid mental height is the height between the anterior border of the thyroid cartilage and the anterior border of the mentum of the mandible. And we aimed to evaluate the usefulness of such a predictor of TMHT as a single predictor of intubation using Carlin's tubes. We have performed measures of 142 patients. They were all planned thoracic surgeries. No emergency procedures were taken account for. 87 patients underwent video-assisted thoracoscopic surgery and 55 patients underwent thoracotomy. The baseline characteristics of our group are as follows. The average age was 61.2 years. The average weight was 77.4 kilos. The mean height was 168.8 centimeters, and the mean BMI was 27.1. During the preoperative assessment, we evaluated the mentioned TMHT, the thyromental length, which is the distance between the thyroid cartilage and the mentum, the anterior border of the mentum. The sternomental length, that's the length between the manubrium sterni and the anterior border of the mentum, as well as the Mallampati scale. Mallampati scale. And during intubation, the anesthesiologist that did the intubation assessed the Cormagley-Haines scale and noted if a difficult intubation occurred. The results we had, they were analyzed using Statistic 10 software. You can see 85% of the patients, that's 120 patients, had normal intubation, and 15%, that's 22 patients, had difficult intubation. And the results are shown in box plots. The small little square here is the median. The box encompasses values of the second and the third quartile, and the whiskers, they show maximum and minimal values. We can see here on the slide that TMHT proved to be significantly higher in cases of normal intubation. The median value was around 55 millimeters, whereas in difficult intubation, it was less than 50 millimeters. That's one of the parameters that was significantly different. And on the other hand, the Cormagley-Haines scale value was significantly higher in patients with difficult intubation than in patients with normal intubation. Remaining parameters, such as the Mallampati scale value, the thyromental distance, and the sternomental distance, were not statistically significant. And after performing analysis using the general linear model and the logistic regression, we can see that both TMHT and Cormagley-Haines scale are significant when it comes to predicting difficult intubation. The odds ratio for TMHT is 0.93, and the odds ratio for Cormagley-Haines scale is 2.97. The rest of the parameters were not was not significant, statistically insignificant. After analyzing the ROC curve for the TMHT, we came up with a value, with a cutoff value for determining difficult intubation, predicting difficult intubation using TMHT, and the value turned out to be 50 millimeters. So the value for TMHT for predicting difficult intubation is 50 millimeters, with specificity and sensitivity being 70%. So to conclude, TMHT may be used as a single by-the-bed preoperative test to predict difficult intubation, and as such, the parameter is equally useful as direct laryngoscopy. That's it. Thank you for your attention.
Thank you for your presentation. Let's proceed to the discussion. Are there any questions or comments? Okay. Okay, thank you. Now I'd like to call on Andrzej Hałek to make his presentation, Differences in Clinical Profile between Patients Suffering from Primary Systemic Vasculititis and Systemic Lupus Erythematosus treated at Intensive Care Unit.
Okay, good morning, ladies and gentlemen. My name is Andrzej Hałek. I'm a student from Jagiellonian University, and I would like to present you results of our study. To begin with, systemic lupus erythematosus, SLE, and primary systemic vasculititis, PSV, are rare diseases and very rarely treated on intensive care units because of autoimmune disease complications and the disease progression. The 40 patients included to the study were probably the best part of all PSV and SLE patients from southern Poland treated on intensive care unit between 2001 and 2014. All these patients were admitted to the intensive care unit on the second department of internal medicine in Krakow. From the 40 patients included to the study, 27 females, 1 male suffered from systemic lupus erythematosus, 5 females, 9 females, 5 males from granulomatosis polyangiitis, 4 males from microscopic polyangiitis, 2 males from Gutt-Pasture syndrome, 1 female from eosinophilic granulomatosis polyangiitis, and 1 female from generalized vasculitis of unknown origin. To compare both groups' morbidities and to assess their predicted mortalities, 5 different intensive care scoring systems were used. I will shortly characterize them. SOFA, Sequential Organ Failure Assessment score, is considering 6 main organs involvement. This scale was designed to provide simple daily score and to compare them. That's why we calculated on admission on the 3rd day and on 7th day of hospitalization. Apache second, that is acute physiology and chronic health evaluation scale, is complex, and its higher score corresponds with more severe disease and a higher risk of death. Apache third, a later scale, measures severity of disease by comparing 20 physiological variables and is designed to provide initial risk classification. SAPS second, simplified acute physiologic score, and its supplement SAPS third are European intensive care unit scoring systems, which resulting values, according to some studies I read, are better at comparing patients with different diseases. SLE in general population is over twice more frequent than PSV, 500 versus 250 per million. It is also more recognizable disease because of inter alia, often quite specific skin manifestations. It reflected in our study results in which time from the diagnosis to the intensive care unit admission was 68 months for SLE patients and only 19 months for PSV patients. The main reason of intensive care unit admission was in both groups acute respiratory failure. Patients suffer from SLE were younger. As you can see, before the intensive care unit admission, more patients with SLE underwent long-term corticosteroid therapy, and larger variety of other immunosuppressants was administered to them. Length of stay was similar in both groups with median of 8 days. On the ward, despite of quickly developing multiple organ dysfunction syndrome, MODS, immunosuppressive therapy was administered to most of the patients simultaneously with broad-spectrum antibiotic therapy. More PSV patients received cyclophosphamide therapy, and in more percent of them, plasmapheresis were performed. What's interesting, despite of worse prognosis on the admission, for example, I presented scores comparing results sub-second score. The mortality of patients treated with cyclophosphamide was comparable to others. Mechanical respiratory support was used in 86.4% of PSV patients and 71.4% of SLE patients. Number of days without mechanical respiratory support during intensive care unit stay was importantly longer in SLE group. Alveolar bleeding was diagnosed significantly more often in PSV patients, 50% versus 7.1%. Sepsis was diagnosed with similar frequency in PSV and SLE patients group, about 30%, but C-reactive protein serum levels were higher in PSV group, mainly 152 versus 103 milligrams per liter. Kidney failure occurred more frequent in PSV patients. It reflected in more often and longer renal replacement therapy usage in this group. Also, median of maximum recorded blood creatinine levels was significantly higher in PSV group, 400 versus 142 millimoles per liter. Differences in severity of developing MODS, multiple organ dysfunction syndrome, reflected with higher mortality in PSV patients group, 59.1% over 46.4%. These differences was predicted by significantly higher mean SAP second, Apache second and third, and SOFA on admission and 7-day scales results. To sum up, mortality in both groups of patients was much higher than general intensive care unit death rate in Poland. To summarize, patients with SLE have much longer autoimmune diseases history before intensive care unit admission. Despite of similar incidence of respiratory failure and sepsis occurrence, they had more severe process in PSV patients group. Kidney failure occurred more often in PSV patients group, and they demand also more frequent and longer renal replacement therapy. Mortality of patients treated with cyclophosphamide was comparable to others, despite of their poor prognosis on admission. Intensive care scoring scales results reflected the differences between morbidities and mortalities between patients with PSV and SLE. The main conclusion is that among autoimmune diseases, the primary systemic vasculitis present to practitioners, especially on intensive care units, are real challenges because of quickly developing MODS, multiple organ dysfunction syndrome, accompanied by sepsis and necessity to provide immunosuppressive therapy. Thank you for your attention, and I would like to invite you to the discussion.
Thank you for your presentation. Are there any questions or comments? Okay, thank you. Now, Sonia Osadnik is going to present her research, Influence of Location on Out-of-Hospital Cardiac Arrest Survival, Urban and Rural Outcomes.
Good morning, ladies and gentlemen. My name is Sonia Osadnik, and today I would like to talk about the influence of location on survival after out-of-hospital cardiac arrest. As we are all aware of, cardiovascular disease is the leading cause of death in Europe, accounting for over 4 million deaths annually. According to the latest available European cardiovascular disease statistics, if we sum up all deaths due to coronary heart disease, stroke, and other cardiovascular diseases, they will account for 42% of all deaths in males and 52% of all deaths in females. Now, looking at the Polish population, we can see that in the first age group, both in urban and rural areas, CVD is accountable for about 1/6 of all deaths, while in the third age group, over 65 years, it accounts for over a half. Also, we can see that in all age groups, the mortality rates from CVD are bigger in rural areas than in urban ones. Chain of survival is a set of 4 most important factors influencing survival after out-of-hospital cardiac arrest. Those include early recognition, early CPR, early defibrillation, and early intensive care. The aim of this study was to assess the extent to which location influences survival and to recognize the difficulties in applying the chain of survival to both settings. We gathered the data using forms filled in by EMS services. The forms were Ochten standardized forms, and they contain various resuscitation data, such as EMS arrival at scene, witnesses being present, also bystander CPR, etc. Our research, we had data gathered within almost 1.5 years. We had 5,340 reported cases. 67% of patients were male, and the median age was 60 years. Resuscitation was attempted in 2,415 cases, and we found that the likelihood of resuscitation being attempted does not differ as a function of remoteness. We also found the incidence of out-of-hospital cardiac arrest to be the same in both areas. Now, looking at the key scene factors, we found that the likelihood of both a witness being present at scene and bystander CPR being performed was higher in rural areas. A shockable initial rhythm was occurred a bit more often in urban settings, but we did not achieve statistical significance. We also found that the likelihood of the witness receiving instruction from the dispatch center was bigger in rural areas. An analysis of etiology of cardiac arrest showed that in both rural and urban areas, cardiac disorders were the most common underlying cause. And cardiac arrest of traumatic origin was more common in rural areas, and cancer-related one in cities. EMS response time was calculated from the time of call to EMS arrival at scene. We found differences between urban and rural groups, which we can see on this graph, here urban and here rural. The median response time in urban areas was 6 minutes, and in rural areas, 12. We also found that a second-tier ambulance was more likely to be present at scene in cities, while a first-tier one in rural areas. A second-tier ambulance is when we have a doctor on a team, and in the first-tier ambulance, we have paramedics only. The survival endpoint for this study was return of spontaneous circulation. And while we have a slightly bigger percentage of ROSC in city cases, we overall found chi-square analysis revealed that there were no significant differences. In the selected group of witnessed out-of-hospital cardiac arrest of cardiac origin with initially shockable rhythm, we found a significant relationship between response time and survival. In the surviving group, the median time was 7 minutes, and in the non-surviving was 10 minutes. And in this group, we found a tendency towards higher survival rates in cities. We can see that 52% of patients in urban areas achieved ROSC, and in rural areas, only 43. There are also significant differences in response times in both groups. Now, as I have pointed out before, The application of chain of survival is crucial to good outcomes after out-of-hospital cardiac arrest. And in rural areas, longer response rates hinder two important elements of the chain, so early defibrillation, early advanced care, while in urban areas, lower rate of witness cardiac arrest hinders early recognition and early CPR. In a selected group of witness cardiac arrest of cardiac origin, we found that shorter response time is essential for better outcomes. That's because in this group of patients, early defibrillation is the most important factor. Overall, in both locations, there are difficulties in applying the chain in different areas, which overall contributes to the fact that we found no significant relationship between location and survival. However, this study identifies areas in which placing further attention could result in improving outcome. Thank you for your attention.
Thank you for your presentation. Let's proceed to the discussion. Are there any questions or comments?
I'm just wondering if you compare your results with the results of the studies made worldwide, because this is quite often investigated subject. Did your results were similar, or there were some differences?
Okay, so this is a popular subject for research, but not necessarily comparing rural and urban areas. And as for overall results, without comparison, it is quite similar to most European countries. And I haven't found any research comparing rural and urban areas in Europe. But for example, in Australia, there were such studies. And there they found more difficulties in the remote areas, but you kind of have to keep in mind that Australia it's always bigger distances. So maybe that's also why, and the response time were longer in that study. That's where they found significant relationship. So
okay, thank you.
No further questions. Thank you very much. Thank you, Sonia.
Okay, now I'd like to introduce Przemysław Dolder, who's going to make his presentation assessment of the fibrillation technique used in cardiac arrest treatment in Poland on example of Lower Silesia.
Thank you. Okay, thank you. Good morning, my name is Przemysław Dolder, and I have an honor to present effects of my team's work. According to European Resuscitation Council 2010 guidelines, self-adhesive pads are recommended for defibrillation as they are safer and more effective method of defibrillation. However, little countries implement that recommendations. We decided to check how it looks like in Poland, and we started from Lower Silesia. It was the voivodeship which we consider the most representative, but we plan to question all Polish intensive care units, coronary care units, and emergency departments. Our aim was to define most common problems and standards of treatment. After gaining the Bioethical Committee approval, we've made a database of departments and started collecting data. Exclusion criteria was lack of defibrillation by the respondent in the past 6 months. We've attended 3 phone call attempts. We've asked about used equipment and standards of treatment. As you can see, we asked about work experience, specialty, and amounts of beds in hospital. We've collected 43 questionnaires, which is 65% of departments, and 4 respondents didn't meet criteria of the study. We are curious if physicians have taken part in ALS causes. Internal medicine specialists and the other were the groups with the smallest percentage of non-learners. while 35% of anesthesiologists and 50% of cardiologists haven't taken part in ALS causes in the past 5 years. Most common methods of first evaluation were 3-lead ECG, it was 51%, and quick assessment with manual paddles, it was 31%, while during CPR it was 71% of 3-lead ECG and only 15% of manual paddles. 92% of physicians use manual paddles as the main method of defibrillation. The rest use only self-adhesive pads and manual paddles both. What was strange, maybe curious, is the fact that nobody uses only self-adhesive pads. And why they are not used? Over 40% of respondents says that they are more expensive and they have some logistic problems. 15% says that manual paddles are safe and efficient enough. Also 50% says that self-adhesive pads are more difficult to use and it takes more time to use them. Other responses included lack of proper training and team habits. And now it's time for charging paddles. What was strange was the fact that more than 50%, it was 53% use, 53% charge them in the air and then place them onto patient chest. And the second, by far less common answer was charging on patient's chest and simultaneously applying chest compressions. And 67% of non-learners, also 67% with internal causes, and 50% of people with external causes do it in the air. To compare, the amount of percentage of people who do it on patient's chest is slower. And last part of our questions was for questions about overall opinion about safety, easiness, and the effectiveness of pads and paddles. 56% of respondents declared that pads are safer. Also, 56% is the opinion that they ensures better quality of chest compression. 90% that they ensure minimizing gaps during chest compression. Unfortunately, 71% says that paddles are faster than pads, which is not true. And to conclusion, using self-adhesive pads in lower silesia is extremely limited. In Western Europe, self-adhesive pads become more and more popular, while in Poland nobody uses them. There are many reasons of this phenomenon. Some of them are obvious, like economic costs, but the other ones, like lack of training or team habits, should be changed. Especially that majority of physicians is the opinion that they're safer and more effective method. However, they are slower in usage. And 70% of physicians who didn't attend any ALS causes and 35% of physicians who took part in ALS causes use this method approved by ERC. Although there is no proven difference between charging the paddles on patient's chest or on defibrillator, charging them in the middle is unsafe and should not be practiced. 1 out of 3 physicians didn't attend any ALS causes in past 5 years. I would like to thank Paweł Krawczyk, MD, PhD, and all the team. Thank you for attention. If you have any questions, do not hesitate to ask.
Thank you for your presentation. Are there any questions or comments?
I have a question once again. You mentioned the issue of costs a lot, and I'm just wondering how the cost is of this adhesive paddles, because I didn't know it, didn't check it. I use it, but I don't know.
It's about something, I didn't check it correctly, but it's something about 100, 200 zlotys of the...
For one set?
Of the... okay, I didn't check it, but,
okay.
But using paddles is only cost of gel or technical problems, but they're using and their costs, yes.
Okay, thanks.
Are there any questions?
I have no question. I can only speak that it's not cost because it's life. And this first, to use paddles in the ICU is absolutely need for this time, because we use electrotherapy a lot now, and we must repeat that twice, 3 times on the hour. I think is only one choice, and only one choice for us is to make new standard, new guidelines in Poland. And I think it's our only one choice. My answer. Life is not worth cash, you know.
Yes, I'm absolutely agree with you, and you're absolutely right. My question was just to point out that this is very common argument, the money, but when we think about it and we calculate it, and when we consider the main goals, which is in this case, life of the patient, in fact, the cost isn't so relevant.
Do you have any data related to the effectiveness of the resuscitation, the defibrillation with these two methods?
It is said that using self-adhesive pads minimize these gaps during the compression. Maybe the differences isn't so huge, but in recommendations there is the aim to minimize these gaps, and they're also safer. But data with percentage I haven't got now.
Thank you for the discussion. And now I'd like to call on Anna Tarczyńska to give her presentation, Implementation of Therapeutic Hypothermia After Cardiac Arrest in Intensive Care Units, Coronary Care Units, and Emergency Departments, pilot study.
Good morning.
Does jury has any further questions to the last presentation we've had? Does jury need extra time for the question? Okay. So we will proceed. Thank you. Here we go.
Good morning. My name is Anna Tarczyńska, and I hope you have some patience after patience to listen to something about therapeutic hypothermia implementation in 2 Polish voivodeships. Since 2005, European Resuscitation Council recommended therapeutic hypothermia for patients after cardiac arrest. The aim of post-resuscitation care is to restore quality of life. According to ILCOR's guidelines from 2000 and 2003, therapeutic hypothermia is one of the few interventions that can be used to improve survival after cardiac arrest with good neurological outcome. Despite the guidelines, not all of the hospitals in Poland use therapeutic hypothermia. Our study, a pilot study, is an update of a similar one carried out in 2010. Evaluation after 5 years was crucial, especially after new regulations from national healthcare system about the funding of hypothermia. Our aim was to evaluate level of therapeutic hypothermia implementation in ICUs, CCUs, and EDs in 2 Polish voivodeships, and to identify barriers to the implementation process. Our team carried out a telephone survey containing 13 questions relating to specifics of therapeutic hypothermia's usage. A few of the questions were specifically addressed to departments that are not using hypothermia, so we could find out what are the barriers to the implementation process. And we obtained 58 of 98 departments that we had. 24% of responders answered that they are using hypothermia, so it is 14 out of 58 responders. But if we look only on ICUs, the statistics are a little different. As you can see, 34% of all ICUs declared that they use therapeutic hypothermia. And comparing this data to 2010 study, when it was 21%, we can see an improvement. An important finding of our work was that the most common area for therapeutic hypothermia is ICU, as you can see here. The other question was about methods to induce and maintain hypothermia, and the majority of responders answered that most commonly they used cold packing. Dedicated equipment devices are rarely available on ICUs or other departments. Most of the responders answered that they use therapeutic hypothermia in all cardiac arrest rhythms, as you can see here. We asked every department if they have heard about ILCOR's update and Nielsen study about therapeutic hypothermia, about target temperature for therapeutic hypothermia, and 5 of 58 responders answered that, admitted the knowledge. As a reminder, I will add that in Nielsen study, it has been proven that target temperature 36 Celsius degrees did not reveal statistical differences comparing to 32 to 34 Celsius degrees. According to this Nielsen study, we decided to ask specifically about target temperature, and for the majority of responders, target temperature was 32 to 34 Celsius degrees, despite the new findings. Only 1 of all responders claimed to use therapeutic hypothermia pre-hospitally and continue it at ICU. According to Kim's study, pre-hospital use of hypothermia did not result in better neurological outcome in patients after cardiac arrest. Equally important part of the study was to evaluate level of identify barriers to the implementation process. Most of the responders answered that the main reason that they are not using hypothermia are the financial issues. For over a year, national healthcare system refunds the procedure of therapeutic hypothermia in ICUs and CCUs in comatose patients after cardiac arrest. So we wouldn't think it's a problem with finances, but it is rather a matter of awareness among ICU staff about new law. Many of the responders answered that the reason that they are not using hypothermia is that they don't have special equipment. But as we know, it's not necessary to have expensive equipment to induce and maintain hypothermia. That was all most important findings of our work. Now I would like to conclude it. First conclusion is that the most common area for therapeutic hypothermia is ICU. Second conclusion is that the further effort should be undertaken to reduce barriers to therapeutic hypothermia's implementation, not only financial help is crucial, which Polish government provided, but also physicians on ICU could use some facilitations in the forms of documents to ease up and fasten the paperwork. Third conclusion is that the knowledge about current evidence about target temperature of therapeutic hypothermia is low. Many of the physicians we've spoken to wish they had the chance to attempt a training course about target temperature management so they can learn a little bit more about therapeutic hypothermia. And the last conclusion is that pre-hospital use of hypothermia is rare. Thank you for your attention.
Thank you, Anna. Now we can proceed to discussion if jury has any questions or comments.
Okay, but because this is, I think, the last presentation, so I have to ask the last question. This is just about your opinion, because in the light of the recent studies, I think the main goal of hypothermia is not, in fact, hypothermia, just maintaining the steady temperature of the patient and protection protection from uprising from, for example, fever. Do you agree with that statement? So, in fact, hypothermia isn't hypothermia, in fact.
It's now called target temperature management, more commonly.
Yes, exactly.
So we don't know. Maybe there will be in a few days new studies about target temperature, and we will find out that it is better to use 32 to 34. Nielsen showed that it does not reveal differences. So maybe we will find out when there will be ERC resuscitation. European Resuscitation Council has the meeting in 2015, yes? So maybe there will be guidelines how to use and what are the recommendations for this specifically.
Yes, we all are waiting for that.
Yes.
Thank you.
Thank you. Any other questions? Okay.
Thank you, Anna. Let's hear applause for all participants. We've come to an end of the session. Thank you all for your great effort. And now we will let the scientific committee discuss the verdict. Meanwhile, I'll invite you for a short break outside. I'll see you in a couple of minutes.